Hi, in this presentation, we're going to talk about neuromuscular diseases. Contents are general considerations: mononeuropathy multiplex, polyneuropathy, motor neuron disease, neuromuscular junction disease, and myopathy. The definition of peripheral neuropathies is a disease or injury of the peripheral sensory, motor, or autonomic nerves. Depending on which of these structures is affected, we're going to see the clinical symptoms. These can be motor, uh, sensory, autonomic, or most commonly mixed. Mm, there is an initial sensory symptoms and then motor symptoms. This is the most common presentation. The pattern of deficit is also important to differentiate if it is symmetric, focal, or diffuse affectation. If there is mainly in upper or lower limbs affectation, and if there is cranial nerve involvement. This is important because a lot of this is we're going to talk about uh, uh, at the end have symptoms related to this, so this can help us in the diagnosis of the disease. The temporal pattern can be acute or chronic, and also it can be relapsing and remitting or constant and progressive. This is mm, the most common presentation, a progressive disease, beginning in one limb and then expanding to other limbs. Also, history, the age of onset of the disease, infancy versus adulthood. When it begins in infancy, we tend to think hereditary congenital diseases, and when the disease starts in the adulthood period, well, we're going to uh, think more of acquired or degenerative disease. Also, if there is a history of cancer, diabetes, it's important to know this. Also, autoimmune diseases, because there is a strong correlation of some of these neuropathies with autoimmune diseases. Toxins, lithium intoxication, organophosphates intoxication, etc. Alcohol intoxication is also a cause, an etiology of these neuropathies, and other systemic symptoms. Temporal pattern of these neuropathies may be acute when it lasts less than 4 weeks, subacute when it lasts 4 to 8 weeks, and chronic when it lasts the more than 8 weeks. The Depending on this pattern, we can make a differential diagnosis on the disease and different diseases. So in this table, we can see the main associated diseases depending on that pattern. We can classify peripheral neuropathies depending on what is the pattern of involvement of the disease. First, we have polyneuropathy. It's a asymmetric distal involvement of the four limbs. And then mononeuropathy, when there is only a single nerve deficit. In this two, it can be sensory, motor, or both. In mononeuropathy multiplex is a deficit affecting an individual nerves, but in multiple areas of the body, and is usually asymmetric. And radiculoneuropathy is a syndrome where we see dermatomal deficit due to a single nerve root lesion, meaning there is only involvement of a single dermatome, a single dermatome area, but also plexopathy. This can be an injury or lesion to the brachial or lumbosacral plexus. The pathogenesis of peripheral neuropathies is highly variable and depends on what disease we're talking about, but we can classify it in general in these types. When there is neuronal degeneration, meaning there is damage to the cell body. Wallerian degeneration, when there is a lesion, for example here, and everything distal from the injury is affected. All of this is affected. This is Wallerian degeneration. Axonal degeneration means there is diffuse axonal damage. The axon has lesions, for example, here, here, and here. And segmental gemyelination. This means there is only damage to the myelin sheath, this here, but the axon is spare. So these different pathogenesis give us um, a different clinical syndromes, and also the electrodiagnostic studies help us differentiate these types of insults to the neuron. Clinical studies that help us diagnose neuropathies are mainly electrodiagnostic studies like electromyography and nerve conduction studies. These help us differentiate demyelinating or axonal lesions, the type of affected nerves, if it's motor or sensory, the presence of conduction blockade, and also other studies are CSF investigation. Some of the findings we can expect are albumin-cytological dissociation, as we can find in Guillain-Barré syndrome and chronic inflammatory demyelinating disease. Immunological screening, this is where we investigate to specific antibodies that we expect to find in the disease we're suspecting. Some of these are anti-GM, anti-GM1, and anti-GQ1B, and anti-MAG antibodies. We can also make nerve biopsy, but this is not widely indicated because there is a high risk, 10 to 15% of chronic neuropathic pain in the site of the biopsy. We make this biopsy when we have high suspicion of vasculitis, atypical site EP, leprosy, giant axonal neuropathy, and amyloidosis. Mononeuropathy. Peripheral facial paralysis, or also known as Bell's palsy, is a clinical syndrome of idiopathic acute unilateral facial paralysis with an incidence of 1 case in 5,000 people. Some of the risk factors for this disease is pregnancy, diabetes, and there is a major prevalence between the ages of 15 to 45 years. The etiology is idiopathic, but there is inflammation of the seventh cranial nerve in the geniculate ganglion, as seen in imagenologic studies. Uh, for this is a possible role of herpes simple virus 1 reactivation. There is a relation with this virus, with this infection. Some of the clinical findings we can expect is weakness or paralysis of hemifacial muscles. This includes all the muscles of the face, and this is to differentiate it from central facial paralysis when there is usually sparring of the area in the forehead. But in this type of peripheral facial paralysis, there is not all the muscles in one side of the area are affected. There is facial numbness, but no objective sensory deficit, only numbness. There is mild or moderate pain at the angle of the jaw. This is referred by a large amount of patients. And decreased hearing and paracusis may be a relation. Prognosis is benign. 90% of people achieve complete functional recovery with corticosteroid treatment, and up to 70% of patients recover spontaneous without treatment. Trigeminal neuralgia is a disorder characterized by recurrent, unilateral, brief, electric shock-like pains, limited to the distribution of one or more division of the trigeminal nerve. The incidence is 4 cases per 100,000 people, and the risk factors are age uh, higher than 40 years, multiple sclerosis, usually bilateral, and some of the clinical findings we can expect is unilateral right in 60% of cases, pain involving the distribution of the second and third branch of the trigeminal nerve, this right here. Involvement of the first branch, the ophthalmic branch, is very rare, so this is something to keep in mind. The onset of pain is usually instantaneous, severe, um, and the duration is very short, seconds usually. Is triggered by innocuous stimuli in the zone of pain, like touching or other sensory stimuli, and the clinical course can be pure paroxysmal with multiple flares, or concomitant generalized pain in the face in these areas with attacks accompanying. The diagnosis is by MRI, where we can see the trigeminal nerve root entry zone, usually with a vascular compression that can be treated with surgical treatment. In this table, we can see some of the more common compressive mononeuropathies, like the median nerve compressive syndromes, like carpal tunnel syndrome being the most common of all. Also, the tardy ulnar palsy is one of the most common compressive neuropathies. And there are others that are not as common but have a specific clinical findings. So it's important to keep that in mind. Median mononeuropathy at the wrist, or also known as carpal tunnel syndrome, is the most common compressive neuropathy syndrome. The etiology is entrapment due to anatomical location. There is a predisponent factor just because of the anatomical location of the nerve, as we can see in this image, and repetitive flexion or extension of the wrist. Risk factors are mainly occupational. People that spend a lot of time in the computer or have this repetitive flexion or extension of the wrist. Also, diabetes, hypothyroidism, pregnancy, rheumatoid arthritis, and obesity. The clinical findings are pain, paresthesia, or numbness in the first 3 digits that may or may not irradiate to the medial forearm. forearm, but the first three digits are always affected. And A is usually exacerbated with repetitive wrist flexion or extension, and sleep is also exacerbated. The patient can wake up because of the pain, because when you are sleeping, there is flexion and extension without you noticing until the pain is very very severe. Uh, Initially is intermittent, but then as the disease progresses becomes constant, and hand weakness is usually is can be seen and as difficulty in manual labor, and this tell us about a severe long-standing disease. So it's important to notice this. Some of the signs we can see is tenile signs, falling signs, tender muscle wasting, and elicited paresthesia. These are some of the clinical signs that we can see in the examination. The diagnostic studies are principally, the diagnosis is principally by the clinical symptoms, but we can aid us with AMG and nerve conduction studies, where we can see loss of motor amplitude, and this tells us about a severe disease that might not improve with decompression. Mononeuropathy multiplex. Mononeuropathy multiplex is defined as a painful, asymmetric, asynchronous, sensorimotor peripheral neuropathy involving isolated damage to at least two separate nerve areas. So as we seen before, this means there are involvement of a single nerve in multiple areas. This is why it's multiplex. The etiology is an autoimmune attack to the vasculature of the peripheral nerves, resulting in inflammation, occlusion, and ischemia in separate peripheral, cranial, and respiratory nerves throughout the body. So it's autoimmune disease, but it doesn't attack the nerves as such, but the vasculature. So because of this disease is associated with systemic vasculitis. So it's important to keep this in mind. We can see other symptoms in other organs related to vasculitis. Also is associated with viral infections, Lyme disease, leprosy, and tumor infiltration. Some of the clinical findings are complete, different, and unrelated nerves affected in different areas. It's usually presented with acute onset of motor weakness, like wrist drop, foot drop, and facial pulses are the main causes of complaint at onset, and it may present as a neurologic emergency that progresses to respiratory compromise because of the involvement of the muscle respiratory muscles. Differential diagnosis is atypical polyneuropathy and multiple conversive mononeuropathies. Polyneuropathy. Guillain-Barré syndrome is a group of immune-mediated disorders targeting the peripheral nerves. It has an incidence of 1 to 2 cases per 100,000 people. It's an autoimmune disease associated with upper respiratory infection, mainly by Campylobacter jejuni, or gastrointestinal infection, or other gastrointestinal infection. This is seen in up to 60% of cases. And this disease can be uh, categorized in 4 subtypes depending on clinical findings and EMG and nerve conducting studies findings. and the related antibodies. So first we have acute inflammatory demyelinating polyneuropathy. This represents 85 to 90% of all cases, and is the mainly seen as an ascending paralysis with minor sensory symptoms. The antibodies are non-specific, but mainly GQ1B autoantibodies are seen. The EMG NSCS findings are demyelinating or absent F waves. Acute motor axonal neuropathy is seen as 55% of cases, and the clinical findings are mainly flaccid paralysis, and there is a strong association with Campylobacter jejuni. Some of the autoantibodies we can expect to find is anti-GM1 and anti-GD autoantibodies. Acute motor sensory axonal neuropathy, or AMSN, is seen in 5% of cases, and this is an acute disease with profound quadriparalysis, and ventilation often required, is more severe subtype. Also, we have Miller-Fisher syndrome that represents 2 to 3% of all cases, and is its clinical findings are ataxia, areflexia, and ophthalmoplegia. The antibody strongly associated with this disease is anti-GQ1B autoantibodies. Some of the clinical findings we can expect in Guillain-Barré syndrome are initially sensory manifestation, mainly paresthesias or vague numbness in hands and feet. Posterior, there is a rapidly progressive ascending weakness beginning in the distal legs and then involving the arms. Usually there is maximum disability within 2 weeks of onset, but the disease evolution is minor to 4 weeks. Reflexes are decreased or absent. 50% of patients have a lower cranial neuropathy, seen as dysarthria, dysphagia, ophthalmoparesis also, and facial weakness can be seen. 25 to 30% of patients have involvement of the respiratory muscles, and develop life-threatening respiratory paralysis that requires mechanical ventilation. So this is an important complication to keep in mind. And 50% of patients present dysautonomia. This carries a high mortality rates due to cardiac arrhythmias or blood pressure fluctuations. The diagnosis of Guillain-Barré syndrome can be made from clinical findings, and also laboratory studies can help us. Here in this table, we can see the required features for diagnosis and the features that strongly support diagnosis. So when we see these two features and also some of these, we can diagnose Guillain-Barré syndrome. But when we find features that cause doubt on diagnosis, we can either think of other possible diagnoses, or make a study that can help us confirm our suspicion. Laboratory studies, first we have blood count, glucose levels, electrolytes, kidney function, and liver enzymes, and this can help us in the differential diagnosis of other acute polyneuropathies. As I mentioned before, up to 90% of patients have anti-GQ1B antibodies, so we can investigate it for those. CSF examination, the main characteristic is albuminocytological dissociation. This means that the protein levels rise, but the cellular levels, the cells, remain the same. So there is a dissociation. But it's important to keep in mind that protein levels might be normal up to 2 weeks of the onset. Electrodiagnostic studies, we can expect to find reduced conduction velocities, reduced sensory and motor evoked amplitudes, and partial motor blocks. But there is a neural sparing pattern that we can find, meaning that the medial and ulnar sensory nerve action potentials are absent, but sparing, there is a sparing of the sural nerve. Some of the diseases that we have to keep in mind for the differential diagnosis of Guillain-Barré syndrome are acute spinal cord disease, like acute myelopathy or transverse myelitis, myasthenia gravis, botulinum intoxication, and toxic neuropathy. The prognosis, well, the disease the clinical course is usually symptomatic plateau at 2 to 4 weeks, and then there is followed by gradual recovery. 30% of patients develop respiratory paralysis and require mechanical ventilation. 5% of patients die because of respiratory compromise or autonomic dysfunction, and 10% of patients end up having permanent motor deficit. In this graphic, we can see the clinical course of the disease. It has an acute onset, it has a plateau over 2 to 4 weeks, and then there is gradual recovery. Chronic inflammatory demyelinating polyradiculoneuropathy is a syndrome characterized by lesion to the peripheral nerves, causing progressive, symmetric weakness and sensory symptoms lasting at least 2 months. The epidemiology is 7.7 cases per 100,000 people, and it has a higher incidence in men and people older than 50 years. The etiology is an autoimmune disease. Humoral and cell-mediated mechanisms are usually involved. The temporal pattern might be monophasic with a single attack, relapsing and remitting, and progressive. The most common one is a progressive pattern. The clinical findings of CIDP is initially there is distal symmetric sensory symptoms of the four limbs. This can be either positive or negative symptoms. In this table, we can see what are the differences within those. Positive symptoms are paresthesias, pain, and negative syndromes are principally numbness, reduced or absent sensation, or postural instability. Then develops a symmetric, proximal, and distal weakness that may begin focal but becomes rapidly bilateral or multifocal. Reflexes are usually diminished or absent, and cranial neuropathy and respiratory muscles weakness may occur. The diagnostic studies that we can make are nerve conduction studies, where in this table we see the electrodiagnostic criteria for CIDP. And CSF examination, we expect to find albuminocytological dissociation. Diabetic neuropathy presents as an heterogeneous group of neuropathic syndromes associated with diabetes mellitus. The epidemiology is the most common cause of neuropathy worldwide, and is found in up to 2/3 of diabetic patients. The pathophysiology, there are three main theories. Metabolic theory, where there is sorbitol accumulation, and then develops nerve lesions. And also the vascular theory, where there is endoneural ischemia, and neurotrophic factors dysfunction theory, where there is ROS accumulation and lesion to the nerve also. In this table, we can see the clinical syndromes we can find in diabetic neuropathy. The most common syndrome is sensory-motor neuropathy. This usually begins in feet and ascends the legs and affects the arms last. The sensory symptoms are numbness, paresthesia, dysesthesia, hyperesthesia, and ataxia, meaning there is a positive or negative sensory symptoms. Then there is distal weakness and atrophy of the limbs. Then we have small fiber neuropathy. This can be pure small fiber neuropathy. This is mainly seen clinically as numbness, paresthesia, and painful dysesthesia. There is a syndrome known as diabetic neuropathic cachexia. This is a subacute, severe neuropathic pain with rapid weight loss. This is a rapidly progressive neuropathic pain throughout the body, and it's important to differentiate it from paraneoplastic sensory neuropathy. We also have autonomic neuropathy, and the symptoms we can expect to find are, well, erectile dysfunction, orthostasis, cardiac dysrhythmias, diarrhea, and constipation. All of the the muscles uh, innervated by autonomic nerves. Also, we can find ischemic mononeuropathy. The third cranial nerve is the most commonly affected, and there is we can see it with diplopia and pupil sparring oculomotor palsy, also known as diabetic tear. This happens because the parasympathetic nerves that innervate the pupil are usually in the periphery of the nerve, so it's not as affected motor uh, as the motor fibers that are centrally in the nerve. Other regional neuropathic syndromes are diabetic amyotrophy. This is a subacute weakness and atrophy of proximal legs muscles. This is known as Brugger-Garland syndrome, and is accompanied by significant weight loss, intermittent tight pain by maybe seen, and reflexes may be decreased. The diagnostic criteria for diabetic neuropathy are the following. We need the diagnosis of DM according to the National Diabetes Data Group criteria, chronic hyperglycemia, sensory-motor polyneuropathy in lower extremities, and other neuropathies or diabetic retinopathy. Also, we need exclusion of other diseases. The diagnostic studies in patients with no prior history of diabetes, but we suspect diabetic neuropathy, we need to make the according studies for diabetes mellitus. AMG and nerve conduction study help us define the type of nerve injury. Hereditary peripheral neuropathies are the most common monogenetically inherited disease of the nervous system. It has a prevalence of 1 to 4 cases per 1,000 people and is divided into three major categories. Hereditary motor and sensory neuropathies, also known as Charcot-Marie-Tooth syndromes, hereditary motor neuropathies, and hereditary sensory and autonomic neuropathies. Charcot-Marie-Tooth syndromes are the most common of the hereditary motor and sensory neuropathies, specifically the type 1. This is an autosomal dominant chronic demyelinating neuropathy, and the subtype 1A accounts for 60% of all hereditary neuropathies. The etiology is a PMP2 reduplication, and the clinical findings we expect is usually an onset in early adulthood. There is gradual progressive distal weakness with distal symmetric sensory loss. There is also atrophy of the muscles, diminished or absent tendon reflexes, and sensory ataxia that leads to gait impairment. There is also found foot deformities like pes cavus and hammer toe, as we can see in this image, and also we can see deformities in the hand. There is usually severely slow nerve conduction velocities in this disease because of the demyelinating pathophysiology. Charcot-Marie-Tooth syndrome type 2 is the second most common hereditary motor and sensory neuropathy. It is a group of autosomal dominant or autosomal recessive chronic axonal neuropathy. This is not a demyelinating disease, and the clinical finding is usually begins in the second decade, and the clinical phenotype is very similar to the type 1. There is gradual progressive distal weakness, sensory loss in the extremities, and atrophy of the muscles. There is neuronal loss without demyelination, and the conduction velocities are normal. This helps us differentiate between the type 1 and the type 2. These are some of the most common found uh, genes affected in these syndromes. Motor neuron diseases. Amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, is the most common motor neuron disease in adults. It presents in 1 to 3 cases per 100,000 people, and the etiology is 5% of cases are inherited, but the majority of cases are sporadic. The typical clinical findings we expect to see, it depends on the structure affected. In the spinal subtype, we see lymph motor symptoms presented as segmental and asymmetrical upper motor and lower motor symptoms. In this table, we can see which are the clinical findings of this syndrome. In upper motor neuron, we expect to find an increased muscle tone, hyperreflexia, and the presence of Babinski sign. Uh, in lower motor syndrome, we expect to find the decreased muscle tone. There are fasciculation, and muscle wasting and weakness is more present. Also, it can be a reflexia, but the Babinski sign is absent. So in this disease, we expect to find both upper motor and lower motor syndromes in an asymmetrical and segmental pattern. In the vulvar subtype, we find spastic dysarthria, hypophonia, drought head, aspiration of liquids, and difficulty in chewing, but because of the involvement of lower cranial nerves. This is important for the differential diagnosis. There is a sparing of extraocular muscle movements. Also, the bowel and bladder functions are conserved, and the cognitive and sensory changes are not seen in this disease. The diagnosis can be made clinical with the modified El Escorial or Awaji criteria, and but also there are some expected findings in the electromyography and nerve conduction studies. And this we expect to find chronic denervation and reinnervation pattern, fasciculation, and positive sharp waves. but there is normal nerve conduction velocities and decreased motor action potentials amplitude. And this help us for the diagnosis. The differential diagnosis of this disease is mainly structural lesions affecting the brainstem or cervical spinal cord, lower motor neuron disorders and peripheral neuropathies, and inclusion body myositis. The prognosis must live 3 to 5 years after onset. If there is a younger age of onset, they usually have a longer duration of illness. In the spinal subtype, if there is a spinal subtype at onset, this usually carries a longer survival for the person. In this table right here, we can see the different set of criteria that we can use to diagnose ALS. And there is a Lescoral criteria, Awaji-Shima criteria, and the Chinese Medical Association criteria. The most used one is the Lescoral because it's usually shorter. The modified Lescoral is shorter and it's more for clinical use. Neuromuscular junction diseases. Myasthenia gravis is an acquired antibody-mediated autoimmune disease affecting the neuromuscular junction. It's the most common disorder of the neuromuscular junction, and it has a prevalence of 1 case per 10,000 to 20,000 people. It affects predominantly young women, but in the older age, it affects men more. 5% of cases are associated with another autoimmune disease. The pathogenesis of the disease is depends on the type of antibody. In binding or blocking acetylcholinesterase receptor antibodies, there is a loss of this receptor on the postsynaptic membrane via accelerated receptor degradation or blocking receptor or blocking the receptor as such. In this case, we can see the antibody binds and then affects the degradation, or it can bind and block the receptor. Also, there is modulating as ACHR antibodies, and this means there is cross-linking, and it facilitates endocytosis. We can see it in this image. The antibody binds to the receptor, and then there is endocytosis and degradation of this receptor. Uh, other autoantibodies we can find in this disease is anti-MuSK and LPR4 antibodies, and these are less common but are also present. Myasthenia gravis is characterized by fluctuating fatigable weakness of the most commonly used muscles. 85% of cases present with oculomotor symptoms at onset, like diplopia and palpebral ptosis. This is due because these muscles used are used with a great frequency. Also, some of the most common typical presentation is limb and trunk weakness. It's usually more proximal than distal, and quadriceps, triceps, and neck extensors uh, are affected with more frequency. Also, we can find vulvar symptoms like dysarthria, dysphagia, facial weakness, weakness of mastication and nasal speech because of affectation of the brainstem. It's important to note the fluctuation of the symptoms. It increases throughout the day, but worsens with activity and improves with rest. When there is diaphragmatic and intercostal muscle weakness, we expect to find respiratory compromise, and this is also known as a myasthenic crisis. And this crisis is present in up to 15 to 20% of patients, and is usually precipitated by infection, aspiration, or pregnancy. In this table, we can see the severity and the evolution of the symptoms in this disease. First, there is in the stage 1 ocular involvement, and 2A we can see mild but generalized. In 2B, moderately but generalized, and 3, there is an acute fulminating myasthenia gravis with rapid onset and respiratory muscle involvement. In the fourth stage, we can see a late severe myasthenia gravis with severe symptoms, and usually less favorable prognosis. The diagnosis of this disease is made with a detailed history and comprehensive examination. Uh, some of the signs we can find in this disease is sustained upgaze looking or sustained abduction of the arms can elicit fatigability. Like in this image right here, we can see the fatigability of the muscles when looking upwards. There is also serologic testing looking for the antibodies, and of course the acetylcholinester receptors are the most sensitive. The electrodiagnostic studies, we expect to find normal nerve conduction velocities, but with repetitive stimulation there is a decremental response as in this image. And single fiber electromyography, it has the higher sensitivity for this disease, and it shows increased jitter. This is how this we see the increased jitter right here. The ice pack test also is something we can do in the clinical setting, and when we put an ice pack in the eye, we expect to find improvement of ptosis. Also, the edryphonium or tensilon test, we expect to find a clinical response of the ptosis within 30 seconds of 3 milligrams IV. The prognosis of this disease is a progression to maximum severity within 2 years of onset, but there is normal life when the treatment is adequately. Myopathy. First, we're going to talk about the acquired inflammatory myopathies, and the most common one is polymyositis. It presents as a progressive proximal symmetric weakness that develops over weeks to months, so it's acute to subacute. It's usually accompanied with myalgia, shortness of breath because of respiratory muscle involvement, dysphagia because of bulbar involvement, and cardiac involvement in up to 40% of cases. This cardiac involvement, is presented with arrhythmias, cardiomyopathy, and chronic heart failure. Also, these patients also have weight loss, fatigue, and generalized malaise, and is associated with cancer in 5 to 10% of cases. Also, there is an association with anti-synthetase syndrome in up to 10% of patients, and these patients usually have anti-jaw antibodies, and they present with myositis, interstitial lung disease, mechanic hands, fevers, arthralgia, and Raynaud's phenomenon. In these patients, we see elevated CK levels, creatinine kinase level. Also, muscle enzymes are also elevated because of the rupture and lesion to the muscle, lactate dehydrogenase and aldolase. In the AMG, we find profuse spontaneous activity, and nerve conduction studies show low amplitude in motor responses. The muscle biopsy is the definitive form of diagnosis. And we see endomysial inflammatory infiltrates and necrosis and atrophy. Dermatomyositis is a systemic meningoencephalopathy in which the endothelial cell of blood vessels are targeted because of B-cell mediated immune attack. The clinical findings are the same muscular symptoms that we see in polymyositis plus cutaneous manifestations. We see an heliotrope rash with eyelid edema and facial rash, like we see in this image. There is Groton sign, like we see in this image, V sign in this image, and Shawl sign in this image. Also, there is the dilated capillary lobes at the base of the fingernails. These are the most common cutaneous manifestations. The laboratory findings, we also see elevated CK levels, the same EMG findings than polymyositis, and the muscle biopsy is the definitive diagnosis also. It shows perifascicular atrophy, typically. Inclusion body myositis has a different clinical course than the polymyositis and dermatomyositis. We see an insidious, slowly progressive course that develops after the age 15. We see an early distal weakness with the finger flexors and foot dorsiflexors most commonly affected. Also, there is early quadriceps weakness with early loss of patellar reflex and asymmetric weakness. It may occur a mild facial weakness and significant dysphagia also may occur. 30% of patients have a concomitant peripheral neuropathy, and 50% of patients have an associated systemic autoimmune disease. Laboratory findings, we find normal or moderately elevated CK levels, though are not so sensitive and specific. In the muscle biopsy, we see muscle fibers with rim buckles. This is the typical findings. These are the rim buckles at the periphery of the cell, and these buckles contain beta amyloid protein. Now, about congenital myopathies, we are going to talk about the most common ones. There is Duchenne muscular dystrophy and Becker muscular dystrophy. Duchenne is the most common one. It has an incidence of 1 in 3,500 male births. It's most common in males. And it has an X-linked recessive inheritance. The onset is typically in 3 to 4 years after birth, and it presents with a proximal muscle weakness. Also, there is commonly positive gower sign to stand up, and this is a typical posture the patient has to stand up because of the weakness. Also, we can find calf muscle pseudohypertrophy, as we see in this image. Also, it's common to find lordosis and severe scoliosis. By age 12, most patients need wheelchair, and the life expectancy is 20 years after the onset. Becker muscular dystrophy, it has a little different clinical course, but the symptoms are the same: proximal muscle weakness, calf muscle pseudohypertrophy, and this has an autosomal recessive inheritance. The onset is usually after 12 years of age, and as I mentioned, it has a more benign evolution. The gait preservation is usually preserved after 16 years, and the life expectancy is 40 to 15 years. References.